So Coleen is our practice partner here at UCSF. She's a professor of orthopedics. She's got multiple titles and responsibilities. She's the co-director of IGOT, which is the Institute of Global Orthopedics and Traumatology, and CHESA, which is the Center for Health Equity in Surgery and Anesthesia here at UCSF. She's been the chair of International Committee at AAOS. She recently won the Humanitarian Award for POSNA, and as you heard earlier, is doing some phenomenal work in Uganda, in a place where Norgrove worked at as well. So Coleen's going to talk to us about creating a pediatric orthopedic fellowship in Uganda and her experience. So Coleen, welcome, and please take it away.
Thank you very much. It is an absolute honor to be here today. Congratulations to Sanjeev, Jackie, and the whole team for putting together such an excellent webinar. And I am absolutely thrilled to be in this panel with people whom I have tremendous love and respect for the work that they do. So thank you for allowing me to be here today. As Dr. Sabwal said, I'll be talking about developing a pediatric orthopedic fellowship in Uganda. I have no disclosures that are relevant or at all. And I'm going to start with the big picture. I was sort of cutting out a few slides as other people were giving their talks because I don't want to be repetitive, but I do want to provide sort of a context by which this conversation about fellowship training, the context that we're having it, which is that we know that there's a huge unmet burden of surgical disease out there. That was made very clear in the 2015 Lancet Commission report on global surgery, which showed us that 5 billion people lack access to safe and affordable surgical care. And that if we were to meet that unmet burden of surgical disease in low and low middle income countries, we would need to perform 143 million additional surgical procedures per year. The poorest 1/3 of the world's population receive only 3.5% of the 2.3 million major surgical operations that are performed globally. And that surgical disease, we know, accounts for about 30% of all the morbidity and mortality worldwide, accounting for more than 4 times the annual deaths of HIV, TB, and malaria combined. But we also know that the vast majority of funding for what we would consider global health goes into those infectious disease problems rather than in surgical care. If we break that 5 billion down for those who do not have access to care, 1.7 billion of them are children and adolescents, with 1.2 being kids between the age of 5 and 19, and 500 million children under the age of 5 not having access to surgical care. That disparity is horrifically illustrated by this statistic, where less than 3% of children in low-income countries and less than 8% in low-middle-income countries have access to surgical care. That lack of care results in more than 6 million deaths, preventable deaths per year, due to untreated congenital problems, injuries, and cancer. And far greater than that 6 million, children suffer lifelong disabilities from having a lack of surgical access. And certainly we know that a major contributor to this lack of access is an insufficient surgical and anesthetic workforce in many places throughout the world, coupled with inadequate infrastructure, equipment, and supplies, inadequate engagement of governments, and many factors such as poverty, transportation limitations, lack of emergency transport services, and many other things that are part of the surgical ecosystem that results in these disparities. If we look specifically as orthopedic people at orthopedic problems, the burden of musculoskeletal disease globally we know is significant. About 6% of the global burden of disease is non-traumatic musculoskeletal conditions, with traumatic injuries being an even more significant contributor to disability and death globally. And that the disability and death from untreated musculoskeletal conditions is significantly underappreciated because we really just don't have the data, particularly for children. So we could certainly make our argument much stronger if we had data. So a plea for ongoing epidemiologic work in this. So we know from this, what I've shared and what others have shared, that this burden is really great. And what can we do about it? I think all of us in this panel would argue that a focus on capacity building rather than this model of direct service delivery where people from higher resource areas sort of fly in and do a bunch of surgeries and leave, that a capacity building focus has a much greater impact. And that the training and support of local surgeons is really critical for long-term sustainable change if we are to improve access and quality of surgical care globally. So it's based on that premise that we share the work on this fellowship. And my dear friend, Mikkel Steenbeck, in his talk shared a little bit of this perspective, but I always like to use this to help frame maybe why I'm so passionate about work in Uganda. When I'm not in Uganda, I am in California, where we have a population of about 40 million people. We have 2,406 orthopedic surgeons in California, so we have about 1 per 16,000 people. And there are currently 123, more or less, pediatric orthopedic surgeons in the state. So that's about 1 pediatric orthopedic specialist for every 81,000 children in California. Uganda has about 46 million people, with 21 million of those under the age of 14. And they have about 80 orthopedic surgeons. So that's about 1 orthopedic surgeon for over 500,000 people. And if you look at pediatric orthopedic specialists, by 2022, there were 2 fellowship-trained pediatric orthopedic surgeons in the country, Francis Nero, who had trained at Sick Kids, and Judith Nasazi, who had just gotten back from the University of British Columbia fellowship. So we're looking at 1 pediatric orthopedic surgeon per 11.5 million children. Dr. Nero had subsequently moved to a government hospital and was not providing exclusive pediatric orthopedic care. So that number was probably even worse than that. So in comes this phenomenal facility known as Corsu Rehabilitation Hospital. It opened in 2009, was grown from the work of Norgrove Penny, my dear friend and mentor, who had lived and worked in Uganda for a number of years, and started a pediatric orthopedic center at a different hospital, working with Mikkel Steenbeck and his wife, Marike Drisa. They built this, this increasingly large pediatric orthopedic program that then became a standalone children's hospital. And Mikkel was really the one that shepherded this to its opening in 2009. It is initially a Christian Blind Mission funded hospital that has an orthopedic and plastic surgery focus. It's brilliant because it also has an orthopedic workshop. It has PT and OT services. We're just building a rehab center there. And from a musculoskeletal perspective, really the orthopedic issues are osteomyelitis, which accounts for about 20% of the surgical burden of cases that are taken care of there. Angular limb deformities, clubfoot, certainly late presenting trauma, since as you saw in a previous talk, much of the acute trauma is actually cared for by traditional bone setters. So there's a lot of problems of delayed trauma and complications related to traditional bone setting treatment. Very significant neuromuscular population, as well as congenital limb deficiency. Sorry, I'm getting a text from Ethiopia. So our work at Corsu, I started there in 2013, going with Dr. Penny, as he highlighted. We did this osteomyelitis course in 2013, working with our colleagues there. They were really interested in developing some limb deformity work. So we partnered with John Herzenberg, Christoph Radler, and Mark Eidelman to bring a Baltimore limb deformity course to Uganda. And our team there really embraced TSF and took off with TSF. And it was these educational programs that we were doing and working with our colleagues there that prompted us to want to explore a more ongoing, sustained, and impactful pediatric orthopedic program. And so, as Rick had mentioned, the College of Surgeons of East Central and Southern Africa had developed a whole exam in pediatric orthopedics with a fellowship curriculum. And Rick was a huge champion of that. And so we were able to partner with Mark Berry, a retired orthopedic surgeon here from the US, who had started an organization called Coleen. He had done a fellowship in Tanzania already. And so that program and its funding through Rotary came to Corsu, and that's our original group of fellows there at the bottom. And shout out to the other programs in the region. So for people who are trainees on this call, there are fellowships at Cure Ethiopia, Cure Kijabi in Kenya, and the Muhimbili Orthopedic Institute in Tanzania. Rick can let us know if the Zambia program, what the status is there, and hopefully you'll see Uganda as an ongoing program on this list. So we started in December of 2019. They were supposed to take their exams in 2021. And that's this program is based on sort of a monthly rotation of visiting faculty. So as we've talked about, people coming from more high income countries, these were mostly recently retired orthopedic surgeons coming in and teaching. Unfortunately, the faculty were only on site for our program from December 2019 to February of 2020. And then COVID hit. And so we pivoted to a 2-year weekly, or two years. We did a weekly online conference where our fellows had the opportunity to have John Wedge, Norgrove Penny, Elhanan Bar on, Peter Stevens, Mark Berry, myself, a huge group of pediatric orthopedic surgeons teaching conference. And then we started back up again in person in fall of 2022 when sort of COVID restrictions were cleared. That's the list of faculty. So again, you have a number of surgeons coming in for a month at a time, sometimes even a little bit more, and doing this teaching. It was both clinic and OR based. We did 3 morning conferences a week. We had journal clubs, research was a part of it, and then online educational resources. Our first 2 fellows took their exams in December of 2023, who are Dr. Zakello and Iwochu, and they did pass their exams. Our next fellow, Dr. Fisha, and our colleague Judith Nasazi will sit for exams this year, which we're really excited about. And that's our current pediatric orthopedic team from Corsu. In terms of our future, funding is going to be the most difficult thing to ensure sustainability, but it is our hope to have an ongoing training program run by our team at Corsu. We do plan to have 2 fellows per year. And those are 4 Ugandan pediatric orthopedic faculty will lead that work, but we do plan to bring 6 external faculty each year to help, at least for the first few years, to continue to increase everybody's knowledge base. And really the goal is a sustainable, comprehensive pediatric orthopedic fellowship to improve care for children in Uganda and ideally throughout the region. And so just some brief principles that we've sort of discussed, learned, and built on from this fellowship is that it should be locally run and locally championed. It needs to be locally relevant. That's why training in country is so much more valuable for our colleagues than going elsewhere in high income areas with different pathology and much more resources. It's better to do it at home where we see the pathology that they experience every day. And have the resources that they're going to have. A comprehensive team development is really important. It's not just surgery. We have to include physical therapy. It's got to be based on long-term partnerships and really friendships with true bidirectional learning and exchange. And then sustainability, not just in our case, needs to not just be about funding the fellowship, but ensuring the sustainability of the hospital, that patients have access to surgery, because if you don't have any patients to operate on, you can't teach surgery or patient care. We need succession planning, both for the hospital and for the fellowship, ongoing resource access to ensure that people have the tools that they need to implement the skills that they're learning, and then ongoing educational development, mentorship, and support. Thank you very much.